Actually, anyways, so there's a few of us here in BIC 124, and including 2 committee members, and the rest of you are online. So I want to welcome everyone to a doctoral dissertation defense. We've actually had a whole bunch of these in the last couple months, so it's great to see people finishing their long treks. So our speaker today is Wei-Chun Lin, who probably most of you know, has been a PhD student in the department for several years and has now reached hopefully the end. And so I think most people know the usual approach to doctoral dissertations, like thesis defenses where there's a public presentation, public questions, then the public is dismissed and the committee remains, and then the candidate is dismissed and they decide if there's a successful defense. I don't want to take too much of Wei-Chun's time, but let me just give a brief introduction. Again, he's been around the department for several years now as a National Library of Medicine actually postdoctoral fellow, although pursuing a PhD. He originally completed his medical training at Changgung University in Taiwan, where he obtained his Doctor of Medicine MD degree with a double major in traditional Chinese medicine. He then received a Master of Science in Biomedical Engineering from Carnegie Mellon, and then he joined our department in September 2017. And he's going to present his dissertation today.
Okay, thank you for the introduction. So let me share the screen. Can you guys see my screen well? Okay, that's a long time not have a talk in this classroom. So hello, everyone. Thank you for coming. Today, I'm presenting my dissertation work, Application of Machine Learning for Glaucoma Surgical Outcome using EHR data. So glaucoma is the second leading cause of irreversible blindness in the world. In US, there are about 2% of population was affected by the glaucoma older than 40 years old. So what is glaucoma? Glaucoma is a group of eye disease characterized by progressive visual field loss and optic nerve damage, which always related to the increased intraocular pressure. Medication control is a primary treatment plan for the glaucoma to avoid disease progression. However, about 20% of patients eventually need glaucoma surgery. And there are several glaucoma surgical methods, including trabeculectomy, shunt surgery, laser surgery. And trabeculectomy is one of the most common used glaucoma surgery for the advanced patients. In trabeculectomy, surgeon will remove a portion of trabecular meshwork and create a kernel from the inside of eye and to the outside of eye, which drain out the inside eye fluid and decrease the intraocular pressure. However, according to the study reported, trabeculectomy surgical failure rate is about like 28% to 32%. So there are some different definitions of surgical failure. In general, surgical failure was defined as a patient's need a reoperation or showing consistent high IOP or low IOP after 3 months of primary surgery. So those patients might need to take glaucoma medication continuously. Surgical failure are mainly correlated to the postoperative complication, including the high IOP or low IOP or other factors. Scarring is the most common cause for the elevated IOP, and the bleed leakage and overfiltration is common cause of the low IOP complications. Some other complication may be noticed like infection, bleed dyesthesia, malignant glaucoma. In this study, we will focus on the complication related to the high IOP or low IOP since the occurrence of other factors. Postoperative management is crucial and time sensitive. The goal period of the postoperative management is about 2 to 3 months after the surgery. Physicians may adjust their treatment plan and the frequency of the visit for the patient with higher risk of complication. For example, physician may decrease the steroid dosage or delay the laser suture lysis time for the patient with higher risk of chronic hypotony. On the other hand, physician may adjust their treatment for the patient with higher chance of scarring. They might use postoperative anti-fibrotic agent like 5-FU or use higher dose of topic steroid. So overall, the success of trabeculectomy surgery highly depends on the postoperative care, and the goal period is around 2 to 3 months after the surgery. Postoperative management is complicated and may be contrary due to different causes of complication. And the complexity of surgical recoveries and the different needs of postoperative care makes predicting long-term glaucoma surgical outcome more challenging. Therefore, an assistant tool for predicting which patient has a higher risk of long-term surgical failure with different causes will be needed. So my first aim was to assess the possible EHR data that correlated to the glaucoma surgical outcome. And I did a systematic literature review focused on the AI application for eye disease using EHR data. Next, my following aim will address some knowledge gap and limitation we found in specific M1. So in the N2, I developed several machine learning and deep learning model using both structured and unstructured EHR data to predict multi-class surgical outcome, including surgical success, surgical failure due to high IOP, and surgical failure due to low IOP. For the final aim, I try to explain the developed model in the N2 and to identify the important features or explore the impact of this feature on the prediction result. Here is the overview of our study. In the M1, I did a literature review and data assessment. In the N2, developed several machine learning and deep learning model, and the model performance was evaluated by several evaluation metrics. In the N3, we did the model explanation to explore the important feature and their impact on the predictions. So for the M1, the systematic literature review focused on the AI application using EHR data for the eye disease and some risk factor of glaucoma progression and surgery. Also, I explored the different format of EHR data, including the structured EHR data, unstructured data, and the medication list. The literature review work was published in Translational Vision Science and Technology Journal. We found several knowledge gaps and limitations in previous study. Based on our literature review, few studies focus on surgical outcome prediction for glaucoma patient, and there are several notable knowledge gaps. First, most studies use the single measure, such as the IOP before the surgery or the early postoperative IOP, try to predict the long-term outcome. However, there are many factors might correlate to the surgical outcomes, such as eye measures, visual acuity, patient's condition, chronic disease, medication use, or surgery itself. So use single measures sometimes is questionable. And the previous study focused on the binary surgical outcome. That means predict the surgery is success or fail. But the treatment plan for the postoperative complication can be different, as like high IOP scarring patient and hypotony patient, they need a totally contrary treatment plan. And the previous study did not include intraoperative information. Some studies used the data before the surgery, some used the data after surgery in a small period, but lacking the information about the during the surgery. And the sample size is another issue. Most studies, the sample size is smaller than 200 eyes. So there's still really a need to develop a tool to assist with prediction of surgical value due to IOP changes.
Yeah, you can, yeah, you can minimize.
Oh, sorry. Will be better?
Yeah.
Sorry about that. So the first step for the EHR data assessment, we identify the target population for our study. Trabeculectomy performed at KCI Institute from 2010 to 2021. Around 1,500 eyes in 1,300 glaucoma patients were included, and the inclusion criteria was listed below. As mentioned before, our surgical outcome focus on surgical success, value due to high IOP, and value due to low IOP. Sorry. So for the structured EHR data, we select 50 features, including 4 groups: patient's condition and eye measures. Eye measures include the multi-time points of intraocular pressure and visual acuity, and the medication, including the oral medication or eye drop for the glaucoma, or the oral medication for the chronic disease like hypertension or diabetes, and some other information related to the operation itself. And feature selection was knowledge-based and data-driven. Linear imputation was used to handle the missing numeric data. In addition, some variables are incomplete or missing in the structured format, such as conjunctiva report or mitomycin dosage used during the procedure. Mitomycin C is a pretty important anti-fibrotic agent that is used during the surgery that help patient decrease the risk of scarring after surgery. So we need to extract this information from the progress note or surgical note in the free text format. So we developed several regular expression-based tools to extract information and cross-validate information from the structured format and unstructured format to improve the data quality. For the unstructured EHR data, we focus on the surgical note. Surgical note contains intraoperative information and might be useful for the long-term outcome prediction. After data cleaning, we tokenize our raw text and develop a custom word-to-vector model using the SIBO method. And we create a 50 dimensions word vector, and this word vector will input to the prediction model later. Here is an example of surgical notes. Physician may record the mitomycin dosage, the time used, and the patient's condition during the surgery, surgery technique they use, blood loss, and some other information during the procedure. So here's the example for the surgical note. So here's an example of surgical note preprocessing. The raw text will clean up, and the custom stop words and punctuation was removed. And those tags will tokenize, and then each token will link to an index in the custom vocabulary. And those index number will convert to the tensor format, which is an array-like format that used for the deep learning model like PyTorch or TensorFlow. The last part, we try to explore the usability of medication lists. So the first question is medication list accurate? To answer this question, we manually review 150 progress notes, and we found some discrepancies between the progress note and the medication list. Since the manual review is time-consuming and labor-intensive, so we develop an NLP tool to extract the medication information. So we develop a natural language-based model for automatically extract active medication and medication adherence in the free text progress note and demonstrate a prototype medication reconciliation tool using the developed model. This work was published at AMIA Annual Symposium Conference in 2021. Here is the flowchart of the overall overview of the study. The first step, we manually annotate 500 progress notes, and data was split into training and testing. And then we used non-entity recognition to develop a model to extract active medication. The non-entity recognition is a type of natural language process technique seeks to locate the classifying non-entities in the text into predefined categories. In our study, it's like medication name, frequency, or dosage. And we use SPACY library in Python environment, and we create a convolutional neural network to predict each NAND entities. The model evaluation was using F1 score, precision, recall, and the micro-F score for all entities. And we also developed a prototype medication reconciliation tool. Here is the example of annotate nodes, including all entities such as drug name, the route of administration, prescription frequency, the dosage of the drug, medication strengths, the duration, and the medication adherence, and medication use term. Drug name contained generic and brand name and abbreviation. Current medication use term was labeled as drug use and with the blue color, which is pretty important because we use this term to identify the following medications active use and not recording like past history, medication history. So there are some examples of this. Is this label like eye drop, eye meds, start, using, taking, or continuous? The table shows the result for the per entity and average score for the all entities. We can see the model has a pretty accurately to extract medication-related entities such as drug name, frequency, route, dosage, and strengths. But the model shows a lower performance on the duration and adherence. The difference might come from the limited sample size in the training data or the variety of wording for some labels. So overall, the model was very accurate at identifying medication, but less so for adherence and the duration. And the model performance is similar to the best performing published NLP model for medication extraction. With our developed model, we can go back to apply the model as a medication reconciliation tool. First, the NER model extract the patient's medication and the drug use label. The drug use label was used to identify whether the medication are currently used. Then the drug names are standardized based on the ARC's known ingredient. Finally, the medication data was reconciled with the medication list, and the mismatched medication are flagged. We applied this tool on 150 progress nodes and got a F1 score around 95%. So from our medication study, we found the medication list might not be accurately recorded. So if we want to include the medication information as a predictor for the outcome prediction, that's some issue for using each unique medication as a predict, because that will generate a pretty loose data set. So we need to do some dimension reduction. In our cohort, patient in the medication list, patient taking more than 1,000 of unique medication, including the glaucoma medication or corneal disease oral medication. So here is an example. We decided to categorize the medication based on their pharmacology mechanism. So there are 10 unique prostaglandin eye drops in the medication list. And if we categorize them based on the mechanism, then they'll be narrowed down to one group. So by this way, we can reduce the dimensionality and avoid some medication list inaccuracy issue for a prediction model. Here, the key takeaway of the M1. First, cross-validate EHR data with structured and unstructured format could improve the data quality. And the surgical notes contain intraoperative information. It might be useful for the outcome prediction. And medication list accuracy was questionable for glaucoma patients. And the developed NLP tool can be used to help with medication reconciliation. And the categorized medication based on their pharmacology mechanism might be useful for outcome prediction model. In the end, to address the challenging and the knowledge gap for predicting glaucoma surgical outcomes, I developed several machine learning and deep learning models using both structured and unstructured EHR data to predict the glaucoma patient with higher risk of surgical failure after 30 days of primary treatment. Since the treatment plan for the surgical value might be contrary or different due to their cost, so we try to predict three classes as our outcome: surgical success, surgical value due to low IOP, or surgical value due to high IOP. Surgical value is with like scarring and continuous like high IOP is easy to understand. But if after the surgery, the continuous hypotony or the low IOP can be a clinical emergency condition and might some procedure intervention like needling or consider reoperation. So try to predict those two different groups. Surgical value is pretty important rather than just predict surgical success or fail. Besides, in our study, we exclude the reoperation cases caused by the infection and bleep dysesthesia since the sample size is really small. Let's quickly take a look at our study design. We did a data extraction and preprocessing in the first step, and we developed several machine learning and deep learning model, and the model was evaluated by several evaluation metrics. Here is the list of the model we developed. For the using structured EHR data, we developed 5 machine learning models, including artificial neural network, random forest, XGBoost, support vector machine, and logistic regression with elastic net penalty. And the random forest shows the best performance use only structured EHR data. And the 3 text classification model was developed using the surgical nodes, including the one-dimension convolutional neural network model, bidirectional long short-term memory model, and the transformer encoder block classification model. The transformer encoder block classification model shows the best performance. And we also developed an early fusion multimodal with transformer encoder block classification model, try to handle the structured data and unstructured data at the same time. Here is the early fusion multimodal architecture. For the structured EHR data, the continuous feature was normalized and the categorical feature was converted to the 1/2 vector. And the surgical nodes was handled by the transformer block with the setting list here with 10 heads and 12 layers, and the hidden units is 768 with dropout rate 0.1. The output of the transformer block will concatenate with the structured EHR data. And a 2 more dense layer with the batch normalization layer and the dropout layer were concatenated, were connected. And finally, we used the softmax function to predict 3 class outcomes. The hyperparameter we used for the optimized model was listed here. In general, there are 3 common strategies for the deep learning model fusion: early fusion, intermediate fusion, and late fusion. In our study, we found the early fusion shows the best performance for our model. In the previous slide, we showed the architecture of multi-neural network where we used the transformer block to extract information from the text data. A transformer model is a neural network with the mechanism of self-attention and position embedding, which is popular used in many fields such as natural language processing and computer vision. For a classification problem, we only used encoder block to extract information. We don't need a decoder block, which is used for the sequence-to-sequence model. So in transformer encoder block, text data was converted to the pre-trained embedding matrix, and then the position factor is added to the embedded matrix in order to enhance and maintain the position of the word in the text. Another important part is multi-head attention, which contains certain number of different attention layers in order to find out attention words from the sequence. And all these layers work in parallel. So in our study, we used the 10 heads in the prediction model. And the output of each encoder is passed to the next one, and the overall output of the encoder block can connect to the linear layer like here, or concatenate to other input data in a multimodal design like our study. In a transformer block, multi-head attention and positional embedding both provide information about the relationship between the different words and contextual meaning. Therefore, the transformer block can train in parallel and manage text data in a non-sequential way. So compared to the other recurrent neural network like long short-term memory, they treat the text as a sequential data each by each, word by words. So using transformer block can avoid some problem of forgetting of past information in a long text. In our study, even our sample size of the surgical nodes is not big. The transformer encoder block can still work well to extract information from the from those texts. Our data set was randomly split into 80% as training and 20% at testing, and a 5-fold cross-validation was used to avoid overfitting and to the hyperparameter. The model performance was evaluated by AUC score, F1 score, precision, recall, and macro average scores. Here are some explanation of the evaluation metrics. Accuracy determines how correct the value are predicted, and recall is the ratio of correctly predicted class to the all actual class, and precision is the ratio of correctly predicted class to the total predicted class. And the F1 score take care of the information from both precision and the recall and get an average number from these two measures. And ROC curve is a graph showing the performance of a classification model at all classifications ratio. And the area under the ROC curve shows the model ability to distinguish different class. Here we only shows the best performance model from each data format. So blue shows the using both structured and unstructured EHR data, and red is use the structured EHR data only, and the green color shows the use the surgical node only. So we found the multimodal neural network with transformer encoder block shows the highest AUC score and F1 score. So which indicate combine the interoperative information from surgical node with important structured EHR data may bring more information for the surgical outcome prediction. This slide shows the detailed information about the multimodal neural network result. The model has a good ability to identify the IOP cases or low IOP cases surgical value with a recall score higher than 50%, which means the model can correctly identify more than 50% of surgical value case. So for example, in our test data, there are 36 cases with the high IOP surgical value, and our model can correctly identify 20 of them. However, the model shows the lower performance for the precision for the low IOP prediction. So overall, the multimodal with both structured and unstructured EHR data bring a decent result for multi-class prediction. So here are 3 key takeaways from our specific N2. First, multimodal neural network with both structured and unstructured EHR data can be used to predict the multi-class surgical outcome of the primary trabeculectomy. Comparing to the previous study, even try to predict the multi-class that's a little bit more complicated than the binary outcome, our model still has a higher AUC score and F1 score. And the surgical nodes contain intraoperative information is used for the surgical outcome prediction. And the surgical recoveries of trabeculectomy are complicated and hard to predict for the long-term outcome. So developed model could be an assistant tool for the clinical decision making. In the last M, we do an extension study from the specific N2. We try to explain the developed model in the N2 and to identify important feature and their effect on the prediction result. Although the multimodal neural network shows the higher AUC score and have better performance. Currently, there are no reliable model explainer tool for the multimodal design prediction model. So in this study, we focus on the best performance machine learning model using only structured EHR data. We apply the model explainer tool SHAPE on the random forest model to explore the importance and the impact of the features. SHAPE value is again a theoretical approach to explain the output of a machine learning model. The goal of SHAPE is to explain the prediction of any data point X by computing the contribution of each feature to the prediction. With the SHAPE value, we can calculate the marginal contribution of each features and get its impact on the prediction. The basic idea comes from Shapley value. It's a solution concept in cooperative game theory, which was introduced by Leo Shapley in 1951. Here's an illustration example of Shapley value. Assume we have 4 players. They work together for a cargo competition, and they get the award and have some payout. So the question is, how can we fairly distribute this payout? And the Shapley value was used to calculate the marginal contribution for each player, and then we can fairly distribute this payout. So this idea applied to the machine learning. So in the trend model, each feature will work as a player, and the machine learning model will be the game, and the prediction will be the payout. So by this way, we can fairly calculate the marginal contribution for each feature for the prediction. Here's the equation of the Shapley value. Phi represents the Shapley value of a feature I for the one data point, and small n is the total number of features. Big N without the I contain all the possible feature subset not containing the feature I. And the big S is the one feature subset from the big N. The number of S is the size of subset features, and phi x is the trend model prediction function, and small x is the factor of feature value of a data point. And the red rectangle shows the marginal contribution, and the blue rectangle is the weight for the combinations. So overall, Shapley value is used to calculate the local feature contribution for each data point. And we can also get a global interpretation like feature importance based on the aggregation of Shapley value. The figure shows the global feature importance in our random forest model. Since we want to know the global importance, we can average the absolute shape values per feature across the data. And the feature with larger absolute shape value are important, and then we'll sort the feature by decreasing the importance. So in this plot, the most important factor is intraocular pressure 2 to 4 weeks after the surgery, which is similar to previous findings from study that showed the postoperative IOP day 30 during that period is the most important predictor for the long-term high IOP. And some other factor like patient's age, the medication use, and previous surgery are also important in this important feature importance plot. Also, the feature importance plot is useful, but how can we tell the effect of each feature for each class? So we can use the shape summary plot. Here is the shape summary plot in our study for the surgical value to do the high IOP. So in the shape plot, each point is a shape value of a feature for a data point, and the y-axis is determined by the feature. And the features are ordered according to their importance, and the axis shows the shape value. And the color represents the value of the feature. It's not for the shape value, it's for the feature value. And the overlapping points are jetted in the y-axis. So the feature summary plot shows the basic relationship between the value of feature and the impact on the prediction for each class. If we want to dig deeply for the independent or a single feature and their correlation to the prediction outcome, and have a more clearly relationship plot, we can use the shape dependence plot. This figure shows the feature dependence for the IOP value in 2 to 4 weeks after surgery is the most important feature in our study. So the shape feature dependent plot shows the local feature importance over all feature value of the data. The y-axis is the shape value. It's indicate the impact on the prediction, and the x-axis is the value of the feature. So and each point are the data point, specific data point we use in the shape model. That can be the test data or training data. Here we use the test data to explain the model. And in the dependent plot, the positive shape value means increase the predict risk of the output class, and the negative shape value means decrease the predict risk of the output class. Actually, in the shape summary plot, each row was projecting from the point of the shape dependence plot on the y-axis and recoloring by the feature value. In the following slide, we will show several summary plot and dependent plot about our important feature finding in the random forest model. Here is again the postoperative week 2 to 4 IOP mean shares. So we can see a clear linear relationship between the feature value and their prediction effect on the surgical value due to high IOP. And the higher IOP increase the predict risk, and low IOP decrease the predict risk. Here is another example of important feature as a binary inputs. So the prostaglandin medication, if patient did not use this, so that will increase the predict risk of the surgical value due to a high IOP, and decrease the risk if patient used the prostaglandin. And the prior cataract surgery feature shows the contrary effect compared to the prostaglandin eye drops. And here is another feature which is less important, which is the postoperative IOP day 2 to 14. So we can see there is no clear relationship, and with pretty the range of the shape is pretty small. This is the same as clinical findings, since after the primary surgery, the IOP is always fluctuation during the first 2 weeks, and so that's less the prediction power is, yeah. And here's the summary plot for the surgical value due to the low IOP. Right now, it's not for the high IOP. So we can see the postoperative week 2 to 4 IOP is still the most important one, and shows a linear relationship. But compared to the high IOP case, the linear relationship is not as clear as the high IOP. And in the low IOP prediction, low IOP surgical value prediction, the low IOP during that period increased the predict risk. Here is a prostaglandin eye drop for the surgical value due to low IOP. So contrary to the surgical value due to high IOP, prostaglandin use before the surgery will increase the predict risk of surgical value due to low IOP. And other than the surgical value plot, we can also explore the surgical success plot. So here is, well, again, the postoperative week 2 to 4 IOP is still the most important one. But in its dependency plot, we can see there's no clear linear relationship, and we can find there's many points that has the same feature value, but their effect can be positive or negative. So which indicates if you want to use a single value, even if it's the most important one in our model, make the prediction for the long-term outcome will be pretty difficult. We also noticed that age shows a linear relationship for the surgical success rate. Senior patient increased the predict probability of surgical success, and a younger patient shows decreased predict probability of surgical success. So from the N3, we found the IOP measure in the 2 to 4 weeks after surgery is the most important predictor of the long-term surgical outcome for both structure value, so which is similar to the previous study finding. And we also found some interesting features like postglanding eye drop use before the surgery and prior cataract surgery, or the linear relationship of the age and the surgical success rate. This feature haven't been clear study, or the result is controversial, so it can be a possible risk factor of the surgical outcome for the future study. The key takeaway from this N3 is machine learning model with a structured EHR data has a predictive power for surgical outcome, and the model explainer can provide insight into the important features associated with the multi-class outcome. And the identified factors can be used to improve the clinical care or help with the direction for a future clinical study. However, there are several limitations need to be noticed. Also, our data set was one of the largest clinical observation data set with detailed information about trabeculectomy outcomes. The sample size is still limited due to the nature of the study in a single institute. Since the study was performed at a single institute, the result might not be generalizable to other healthcare systems. And we currently don't have a reliable model explainer for the multimodal neural network model explanation. In the future, to improve the accuracy and the generalizability of the model, we plan to combine image data such as OCT data before the surgery in our multimodal neural network and include data from other institutes. Also, because of the novel finding from the model explainer, we are planning to perform a retrospective clinical study focused on the trabeculectomy risk factor with multi-class outcomes. So in summary, my first study explored the AI application using EHR data for eye disease, showing there were limited study focused on glaucoma surgical outcome prediction with several notable limitations. And I clean and validate the structured EHR data with unstructured EHR data, improve the data quality, and develop a custom word embedding model for the surgical node. Also, I figured out the accuracy issue of the medication list for the glaucoma patients and develop a medication reconciliation tool using the natural language algorithm. And the usability of medication list for the prediction model was also explored. Overall, this work has the implication in improving the data quality and the usefulness for the medication data in both research and clinical care. In the N2, I developed several machine learning and deep learning models with structured and unstructured EHR data to predict the multi-class surgical outcomes. This study is one of the first and largest clinical observation data set with detailed information about the trabeculectomy outcomes, combine both structured and unstructured EHR data. Also, the usefulness of surgical nodes as a predictor in the multi-class outcome prediction model was presented. It has a potential to apply this concept to the other clinical specialty. And the multimodal prediction neural network could correctly identify 50% or more surgical value cases. So it can be an assistant tool for the clinical decision making. And lastly, in our specific N3, we developed the model explainer for our random forest model to identify risk factor associated with the high IOP or low IOP surgical value and explore their importance and their effect on the surgical outcomes. So I would like to thank you, my mentor, Dr. Michelle Weber and Dr. Michael Chen, and all my committees. Thank you for your time, your support, and your guide, and really appreciate it. Also, I would like to thank you, all my research group members, Jimmy, Adam, Aaron, Isaac, and Ernest. I got a lot of help and many pleasant hours work with you guys. And thank you for the wonderful staff and faculty in OSHU at DMICE and the KCI Institute. Especially, I want to thank you, Diane, Andrea, Virginia, and Abby. I got a lot of help along the way. Besides, I want to thank you, my fellow student and the qualified exam cohort, Rose, Lily, Mina, Da, and Chris, and all DMICE fellows. And I want to thank again for my mentor, Dr. Michelle Weber, for all your support and your insightful suggestion for my projects. Also, I would like to thank you again for the Dr. Michael Chen and Dr. Karen Eden for advising me to start my PhD journey and supporting me along the way. And finally, I'd like to thank you, my family, especially for my wife, my parents, and my sister, and the funding from the National Library of Medicine. Yeah, so that's my work. Thank you for listening.
You stop sharing your screen so we can see if there's questions. And next, I have a question.
Let me start sharing.
Yeah, that way, just so we can see the. Whoops.
Sync is here. Yeah.
Are people still there?
Oh shoot, this is gonna.
See, so I'm muted. You can't get to.
Slides or?
Yeah.
Okay.
Well, not the slides, but the WebEx. Just
It's yeah, the WebEx is in my monitor, but I
okay.
yeah.
Okay, so then I'm gonna quit out of this.
Some connection issue.
Okay, you can. Here, let me just take a look at it.
Yeah.
So.
My screen is still the WebEx. So.
Oh, okay, interesting. The screen here is
Connection
okay.
or something.
Well, let me and are there so people can either type questions in the chat or can unmute. But I'm gonna take the prerogative and ask the first question. The medication reconciliation. So you said there was a 36% error rate?
Discrepancy.
Discrepancy.
For our manual review, 150 progress
Okay.
note.
And but so between what was in the progress note and like the medication list, or
Yeah, because we included some counterpart. I mean, not the it's some like artificial fluid or some not like hospital prescription medication as our list.
And what was the direction of the errors? Was it like
some error come from like duplicate prescription and prescription actually stop but not showing in the medication list, and some other is like patient take medication from the other pharmacology pharmacy, but they not taking medication from the OSHU, so the medication list doesn't list this medication.
Okay, and so your gold standard then was what was in the note?
Yeah, we assume it's not can be like purely gold standard, but we believe especially we try to extract active medication. So that means like physician will record some like drug use, patient is like taking or starts. So we try to focus on the active medication. We assume that's more reliable.
Yeah. Okay. And then you kind of you sort of narrowed it down into categories, which actually makes a lot of sense. So I mean, I guess well, that kind of clarifies things. And I mean, I guess maybe the question is, is there concern about the, well, I guess your assumption is that you're mapping the different drugs into the specific categories, and so that is what goes into your model.
Preserve some information.
Mhm.
Well, actually, in the beginning, we try to treat each medication, unique medication,
Yeah.
use some embedding method similar
Yeah.
to the word embedding.
Mhm.
So we try to the word to factor, treat each medication as a word and each visit as a sentence or recommendation system
Yeah.
to get the medication embedding. But probably due to the sample size and then there are too many unique medication, we input this medication embedding in our prediction model, but they cannot converge and make things mess up.
Okay.
So we figure out that's probably like issue of medication list itself or the noise generated during we train the medication embedding. But it's interesting try.
Yeah, okay. Yeah, I mean, it just goes to show the challenges of working with EHR data. This is just another example of it. Are there other questions? Yeah, why don't you go ahead and I don't know if there's any further up, and there's a few congratulations and so forth. But there's a question from Nate there.
Yeah, for our transfer in Nat asked, I don't need to read again. Yeah, so we don't use the pre-trained model. We just use the transformer encoder block that architecture, and with our pre-trained 50-dimension word embedding to extract this information to concatenate with our structured EHR data in our prediction model. So we did not use a pre-trained bird.
If anyone has any questions, they can also unmute. Maybe I'll ask one more question. Your recall precision F score were good, but not perfect. So what are the ramifications of that if people are going to use this tool clinically?
Currently, I think it can be just if that apply into the clinical setting, it can just be a assistant tool to so probably provide some probability of the patient has higher risk of high IOP or low IOP for the long term. So still need to physician and human expert to make the judgment to did I agree this probability or not? Yeah.
Okay.
And since the like limited sample size, we are thinking is it possible include like OCT data before surgery or some collaborate with other institutes to enlarge the sample size.
Great. Any other questions out there? Okay, well, if not, we can leave Wei-Chun to his committee. They may have some additional questions. This is really great work, and it's really interesting to see, kind of a real-world clinical application of machine learning like this. So I'll look forward to future endeavors. So we can excuse, including myself, the non-members of the committee, and then you guys can take it from there.